Good afternoon to everybody. Let's start with the new seminar this week from the CPFT and the University of Cambridge. It's a massive pleasure for me to introduce Simon Gilbody, who is a professor of psychological medicine at the University of York, and also a good friend who has been working for a long time on trying to help people with severe mental illness. And today that is particularly relevant. It's probably the largest, I think it's the largest study ever conducted for how to stop or how to help people with severe mental illness to stop smoking, which is one of the major factors associated with the increased mortality in people with severe mental illness. I will not spend too much time introducing Simon, who will explain us is this very interesting project that has been conducted for a number of years. Perhaps just to remind all of you the fact that the questions, perhaps we will be doing the questions at the end of the talk of Simon. Without much delay, welcome to Simon. Thank you very much for giving this talk. Up to you.
Emilio, it's my absolute pleasure. So before I start talking into a computer screen, I want you to give me a big thumbs up to check that you can hear me and you can see my slides. Excellent. Okay, so I feel ready to go now. I immediately feel more relaxed. So it's my absolute pleasure to be able to speak to friends and colleagues in Cambridge. I always relish the opportunity to make a visit to Cambridge, take the long train journey to get over there. So I was slightly anxious that we weren't going to be able to give this seminar. So I understand that this is the first time we've been able to deliver this seminar at a distance. So I'm still pleased to be able to talk about smoking cessation and mental health services. And I was asked to give a title for this talk. So I tentatively said about how I would try to tell a story about how we move from rhetoric to reality in relation to smoking cessation. And it's particularly heartwarming for me to be able to speak to friends and colleagues in Cambridge, because when we were looking for co-conspirators to think about moving smoking and smoking cessation out of the too difficult box, we found willing collaborators and friends and co-conspirators in Cambridge. So the programme of research that I'm going to talk about is one that was delivered in lots of sites across the United Kingdom, but our strongest collaboration was perhaps with friends and colleagues in Cambridge. So I'm going to talk about the SCIMITAR programme of work. And this is a programme of work that's been funded by the National Institute for Health Research. And I'm based at the University of York, but I also spend some time working in the Hull York Medical School. So that's one of the newer medical schools. We've only been training doctors in this part of the world for about 10, 15 years now. But York's a young university, but it has a very strong and rich tradition for applied health research and thinking about the economic dimension of health. And I'll touch on those within my talk. So off we go. Hold on to your seats. I'm going to move on to my next few slides. So I'm not physically sat in York just at the moment. I live in the more industrial city of Leeds. So I've got a photograph there to remind me of the beautiful city walls in York and our glorious medieval minster that we have. And it's resplendent in the sunshine. So I think York will probably look like that just now. So York's a lovely medieval city. It's now a university city. We've got this minster, and it's not a million miles different from Cambridge when you walk around. But one of the things that we've been good at over the years, thinking about what we do well in York, is we've built a production line over the past 10, 15 years. And I hope that I've been part of that in some small way. And one of the things that we've got really good at is taking questions that we think are important for the National Health Service and then using this production line that we've got to deliver efficient, large-scale pragmatic trials to help answer these policy relevant questions. And we've conducted a number of pragmatic trials over the years, and Amelia and I know each other from sitting on committees that oversee the funding of large pragmatic trials in the NHS. And this was something that was funded through the NHR Health Technology Assessment Programme. So I hope I illustrate not just the topic, but how we go about answering policy relevant questions. And the question that we have today is around smoking cessation. How can we encourage people who use mental health services to give up smoking, to quit smoking, and to try and address the epidemic of tobacco addiction and smoking-related illness that historically and continues to exist in mental health services. So that's our question. Can we help NHS mental health services to go smoke-free? How do we chip away at that question, and how do we generate evidence in this area? So I'll talk about smoking. I'll give a little bit of background to this. I'll talk about smoking and severe mental ill health, sort of what we know about this topic, and I'll give a little bit of a historical perspective to that. But I'll talk in detail about how we've responded to the epidemic of smoking and tobacco addiction within mental health services with this large pragmatic trial, the SCIMITAR trial, which is, as far as we know, the largest trial of a behavioural intervention for people who smoke and use mental health services. I'll talk about the history of how that trial came about. I'll talk about how we thought about the design of that trial, and I'll talk a little bit about the findings. But hopefully, particularly for people and colleagues who work in the NHS who might want to think about how we implement this research, I'll talk about some of the implications of some of these research findings for both services and for policy, but also for your individual clinical practice. And I'll talk about how we've managed to start to disseminate this programme. So my first graph, and this is the graph that gets us out of bed in the morning in my research time, is an illustration of the profound and widening health inequalities that exist for people who use mental health services. So many of you have seen this graph or a different version of this graph before, and this is taken from longitudinal epidemiological data framed in one of the Scandinavian countries. And I've no reason to think that this isn't any different in the United Kingdom. So we've got a good news and a bad news story here. We've got two lines for men and women drawn from the general population, showing that life expectancy from the 1980s up until 2010 had been going in a positive direction. People's health is generally improving and people are living longer in the general population. And you can see that women live longer than men. But we've also got two parallel lines in red and blue going in the opposite direction over the same time period that shows that the health of people who use mental health services and people with the most severe forms of mental ill health is substantially worse than that in the general population, and that the trajectory is downward. So we've got a health inequality that exists there historically, and it's one that seems to be getting worse over time. So trying to understand what the drivers of this health inequality might be and how we might seek to mitigate this health inequality is a really important programme of work within my research group at the University of York, the Mental Health and Addictions Research Group. And I think how we've thought about this in terms of smoking cessation is quite illustrative of how we might go about tackling this health inequality. So if we were to think about smoking as something that is a health-related behaviour that is bad for people's health in populations and disproportionately affects people who use mental health services, we can see some temporal trends drawn from the annual surveys that are made of smoking within the broader population. So they've got some triangles bumping along the bottom there from 1993 up to 2013 that represents the prevalence of smoking in the broader population. And this is a real good news story for the NHS. It shows that we've managed to, for the first time, get the prevalence of smoking in the general population below 20%, and it's now probably about 15%. So fewer than 1 in 5, 1 in 6 of the general population are now smokers. But the story is different for people who use mental health services. So here you've got all diagnoses, people with depression, anxiety, or more severe forms of mental ill health. It shows that the prevalence is substantially higher for that population, and the temporal trends are not the same as for the general population. So it's elevated, and it's stubbornly elevated. So the general reductions that we've seen in the broader population haven't been reflected amongst people who use mental health services. And here's a report from Public Health England that makes the same point. So about a third of all the cigarettes that are smoked in this country are consumed by people who have a mental health problem, depression, anxiety, or schizophrenia, or bipolar disorder. And amongst people with the most severe forms of mental ill health, the prevalence of smoking is always more than twice, sometimes 3, sometimes 4 times higher than in the general population, depending on how the surveys are conducted. So this is based on surveys drawn from routine data in NHS digital records, and you will probably know, and if you would think about the people who are admitted to inpatient psychiatric facilities, the prevalence of smoke is probably higher than this. So this is a historical imbalance in the prevalence of smoking, and no one really talked about it. I remember when I started working in mental health services in the early 1990s as a fresh-faced junior doctor. I was always struck by the fact that the smoking culture was prevalent within mental health services. People used to smoke cigarettes in the ward rounds. Staff would smoke with people who were currently inpatients. The culture of smoking was often used. Cigarettes were used as a means of pacifying distressed patients. And here we've got a nice quote that comes from a report. It was the first substantial report into the smoking culture in mental health services that was produced by the King's Fund in the mid-2000s. And it says that people with severe mental ill health enter the services as non-smokers and very quickly become smokers because of this culture in smoking. So I think everyone in today's conversation will recognise what I speak about when I talk of the culture of smoking in NHS mental health services. And to try and understand this, I won't turn to epidemiology, which is usually my first port of call. I'll think about some of the anthropological research that's been conducted over the years to try and understand this. So if you spend some time on mental health in inpatient facilities in particular, anthropologists tell us that they observe these elevated smoking rates, particularly amongst staff, but also amongst people who use services. And staff often accepted smoking as part of the NHS day-to-day routine and would offer cigarettes to people who use their services. Staff would often smoke with users of services, be used as this means of pacifying distressed people. When I started working inpatient psychiatric facilities, they were quite boring places. The level of stimulation was quite low. So patients would often use smoking as a means of relief from the grinding day-to-day boredom that existed there. And inpatient facilities, lots of anthropologists and sociologists have observed are institutions, and like all institutions, there is a cigarette economy that exists within mental health services. So this helps us understand that non-smokers might become initiated into the social rituals of smoking, often upon their first admission to hospital. So we know lots and lots about the health consequences of smoking, often drawing upon the important work of Professor Sir Richard Dole. So we know from his doctor's health studies that smoking is an important driver of poor physical health. And for people with severe mental ill health, we think that this contributes disproportionately to the reduced life expectancy. So for people with schizophrenia or bipolar disorder, estimates vary, but by and large, estimates seem to hit upon reduced life expectancy of about 20 to 25 years. And it costs quite a lot of money to maintain a tobacco habit. So people who use mental health services are often economically disadvantaged, and this also contributes to additional poverty. So people will spend a disproportionate amount of the little disposable income that they have on maintaining a daily cigarette habit of 20 to 30 cigarettes a day. And this increases health inequalities. And I'll just mention there's stigma as well. So people who use mental health services will tell you that they are stigmatized by virtue of being users of mental health services. And one of the things that we've always also noticed in public health, by virtue of the denormalisation of smoking at a population level, is that people who smoke now feel stigmatised. So people who use mental health services feel stigmatised by virtue of being users of mental health services, but also by reason of being smokers. So lawyers in the audience might sometimes recognise that as a double jeopardy, being charged for the same crime twice. So I think it's really important to pay reference and recognise the stigmatisation that happens for smokers and how this contributes to stigma within mental health services. So if you take nothing else away from my talk today, I'd like to impart on you the fact that smoking is the single most important modifiable risk factor for reduced life expectancy, poor health, and health inequalities amongst people who use mental health services. So I've been working in this area about 10 years or so now, and I sometimes encounter resistance to the notion of the fact that we should be researching this as a topic, or that smoking, trying to move smoking out of the too difficult box within mental health services, something that we shouldn't do. And I encounter a series of arguments that are made that would seek to maintain the status quo. So I've got a thick skin when it comes to talking about smoking, and I encounter a series of arguments, and I've learned to try and bust the myths that sometimes go around smoking over the years. So I'll just run through a couple of the myths that I commonly encounter, and maybe you might want to think to yourself about whether, you know, these are things that you've thought about or that you've encountered if you were to think about doing something about smoking and the smoking culture. So the first is that smoking is seen to be a source of stress relief, and people who use mental health services, particularly with the most severe forms of mental ill health, have reason to be stressed for lots and lots of reasons in their lives. And so it's morally wrong to try and do something about smoking to offer people a way out of their nicotine dependence. So often when I encounter that one, if you drill down and you speak to people who use mental health services and are smokers, when they talk about stress, often what they're describing is a form of stress that comes on about 15 minutes after they had their last cigarette, and it represents a sort of sense of disquiet and agitation that's rapidly relieved when they have a cigarette. So often you can reformulate that sense of stress as what it probably is, and that's acute nicotine withdrawal. So that's quite useful. That's often a light bulb moment for thinking about how people's nicotine addiction fits into the way in which they conduct themselves on an hour-by-hour basis, and how the use of cigarettes fits into their repertoire of stress responses. I've got a couple of other myths I'll just run through quickly. If I had a longer talk, I would talk about these in more detail. The second one is that smoking is quite useful for people who use services and who take medication because it relieves the side effects of medication. And there is a neurochemical basis of this argument, but that's never been played out in any substantial applied health research that I've ever seen. So, and this is quite a spurious argument if you encounter it, and, you know, encourage people to take an experiment, try and see if their medication side effects can be relieved in other ways. And there are probably more healthy responses to the side effects of medication. Smoking itself's not a sensible way to respond to medication side effects. The other concern is that quitting smoking can make you unwell. It might cause relapse or deterioration or readmission, often under the Mental Health Act, so it's never a good time to quit. Well, we now have a substantial body of evidence drawn from randomised controlled trials that show that quitting is safe and it doesn't cause a deterioration in people's mental state. And I'll speak a little bit to this during today's talk. And the final one is something that really depresses me, and this is therapeutic nihilism. We shouldn't be in the business of nihilism for the people who use our services, because we encounter that all the time. And the argument goes something like this: people who use mental health services just aren't interested in quitting. So there's no point in asking since nothing works. And we encounter and seek to rebut nihilism in lots and lots of ways for people who use the services in which we work. And I think it's really important that we try to rebut therapeutic nihilism if we were to encounter it more broadly. So the notion that people who use mental health services aren't interested in cutting down or quitting isn't true at all. So I'll just show a slide of the proportion of smokers who are interested in quitting from two places: from the general population, but also amongst people who use mental health services. So the green bars in this slide show the percentage of people drawn from the general population who are interested in cutting down or quitting. So always more than half smokers are interested in cutting down and quitting, and that proportion is almost the same amongst people who use mental health services. So the majority of people who use mental health services and are smokers, if you ask them directly, they are interested in a health message about cutting down or quitting. So this is really useful, gives us a way into the types of interventions that I'll speak about. So in response to the epidemic of smoking within mental health services, we designed the SCIMITAR trial. The SCIMITAR trial ran right across the UK. It ran in Cambridge. We spent a lot of time in Cambridge helping train people to deliver the intervention I'll speak about, and we recruited lots of participants in Cambridge as well. But we've been at this about 10 years, and it was a commissioned piece of research from a priority area identified as being important for the NHS. And I took the trouble, as we published the final results of this trial, to look back at the original research brief that was set, not by us, but by people who commission research in the NHS. And they were really interested in an intervention that was adapted specifically for the needs of people who use mental health services. They were interested in a trial that didn't just ask people whether they were smokers or not, but sought biochemical validation to see if we could actually shift the dial in terms of smoking prevalence for this population. And they were interested in duration of follow-up, not just in the short term, but in the longer term. So I'll speak about how we responded to this brief. So this was an important question, but we immediately found when we sought to follow up this brief that the funder was quite risk averse. They quickly identified, and I think we agreed, that this was a complex and challenging area in which we would need to work. And we convinced ourselves, and then we convinced the funder, that we wanted to do a pilot first rather than just rushing in and doing a full large-scale trial. So we spent some time developing the intervention and then road testing its delivery in the National Health Service. And we also wanted to check before we committed to undertake a large-scale trial that we could actually recruit some sufficient participants in the NHS and then follow them up. So we conducted a pilot trial before we went on and undertook a full trial. So here I've got a slide that I think illustrates the fact that the SCIMITAR programme was built on quite strong foundations. So like lots of people who seek to do research in a new and challenging area, moving from left to right on your screens, we first undertook a systematic review to see what evidence was out there to show what might work. And it suggested that there was probably a role for pharmacological and also behavioural support strategies for people who might want to quit within mental health services. And we also spent some time, and this is the publication in the middle, speaking to people who use mental health services and were smokers and perhaps felt disenfranchised from existing NHS quit smoking services. We found out what they liked and what they didn't like about existing NHS services, and I'll speak to some of the qualitative work as we run through the next few slides. And then finally, on the right, we published the results of a pilot trial consisting of just short of 100 people with largely schizophrenia and bipolar disorder, where we road tested this intervention. And this all pointed in the right direction, but it wasn't a big enough trial to be able to give us a definitive answer. So we've got a systematic review, some qualitative research, and a pilot trial published in Lancet Psychiatry in 2017. So just pinching a quote from the qualitative research, when we asked people what they liked about this bespoke intervention that we designed for people who use mental health services, they said it wasn't just a stop smoking clinic for Tom, Dick and Harry. She, the person who delivered the intervention, understood my mental health problems, which was a big concern. This person told us, if you go to a normal stop smoking thing and they know you've got mental health problems, then I felt stigmatized. I think this was really important. So this framed the way in which we thought about embedding smoking cessation services within mental health services. So we conducted this pilot. We got good at recruiting participants. We road tested the intervention and we established some of the parameters for the full trial. And it turned out they weren't quite right, so we had to tweak things again. But it gave us a preliminary estimate of effect. It showed that we were likely to be able to double the chances of effective quitting. So that's what we shot for in the full trial. So let me say a little bit about the intervention we designed to try and address smoking within mental health services. So we were really keen that we didn't reinvent the wheel. So I got a train from York down to London and spent about an hour with someone who had forgotten more than I would ever know about smoking and smoking cessation interventions, Professor Robert West at University College London. And Professor Robert West taught me more in 20 minutes than I would have got from reading for the next 3 months. He gave us some really sound advice about what a smoking cessation intervention might look like. And he pointed in the direction of something called the Standard Treatment Programme, which underpins smoking cessation services right across the NHS. It's a really well evidenced treatment and training programme that in some way standardises the quality of smoking cessation services in the NHS and ensures that every element of that intervention is underpinned by the best quality evidence that we might be available. But we deviated from the NHS standard treatment programme in a couple of ways that I think are probably quite important. So we firstly ensured that this intervention was delivered by someone who had a good working knowledge of the challenges faced by people with the most severe forms of mental ill health and people who knew their way around mental health services. So for the first time, this was delivered by a mental health professional. So by and large, people were people with a mental health nursing background. We also offered people the opportunity to use nicotine preloading to try and minimise some of the withdrawal symptoms and to use a cut down to quit approach so that people could reduce their nicotine cravings and hopefully cut down their numbers of cigarettes that they smoked so that they felt more confident in making that important next step, which was setting a quit date. And we think the intervention was probably more intensive and certainly more personalised than that which might be available with the NHS standard treatment protocol. And we paid some special attention to medication management. So trying to ensure that we were able to reduce the doses of people's psychotropic medication, particularly their antipsychotic medication, when they gave up smoking and when some of that harmful things in tobacco smoke stopped inducing some of the liver enzymes that they use to metabolize antipsychotics. We spent quite a lot of time planning for a quit attempt, but also a lot of time thinking about what people might do in place of their smoking habit, what they might do to fill the tobacco-shaped hole in their lives. So this was a pragmatic randomised controlled trial. We tried to minimise the exclusion criteria, tried to maximise the opportunities for people who were representative of the populations that use NHS mental health services were encouraged to enrol in this trial. So I'll say a little bit about the design over the next few slides. So it was a big trial. So we recruited 526 very heavy smokers, people with predominantly diagnoses of schizophrenia and bipolar disorder. And we recruited in 21 NHS trusts. Our participants were on average middle-aged, so 47 years, and often had very long histories of smoking. As you might expect for this population, their weight was above population averages. They had quite high BMI. And we randomly allocated people to either receive the bespoke smoking intervention that I just talked about, or to be signposted to what represented usual care in their NHS setting at that time. And we measured outcomes at 6 and 12 months, and our primary outcome was sustained quitting, where we ascertained that by asking people if they'd smoked in the last 7 days and also checking that they were abstinent by asking them to breathe into a carbon monoxide monitor. And we looked at a few other things, so mood and anxiety. We also looked at people's nicotine dependence using the Fagerstrom test and also their motivation to quit. We looked at their quality of life using the short form instruments, and we kept an eye on people's BMI to see if quitting caused them to put on weight. And the short answer to that is it did. Make them put on weight if they did successfully quit. And we also looked at people's medication use and health service use to help us think about the cost effectiveness of this intervention. So it was a challenging trial. We thought that there wouldn't be much interest in the NHS, but we were overwhelmed by the enthusiasm we saw, and that was no more apparent than in Cambridgeshire and Peterborough, and we overshot our recruitment target. So we recruited more people than anticipated, and in a shorter time period. So who got what? So in this bespoke smoking cessation intervention, by and large, people engaged well with it. So 88% of people engaged with the intervention, and on average, they engaged and completed 6 sessions. And these were largely delivered face-to-face, and on average, they lasted about half an hour. The mainstay of the pharmacological support that people received was nicotine replacement therapy. GPs were very, very anxious about the use of the most commonly used smoking cessation support, varenicline, and that's because there's been some suggestion that this might adversely affect people's mental states, and using this medication might precipitate relapse in amongst people who've got a history of mania, but also suicidal ideation as well. So at the time, people were quite cautious about varenicline. Lots of research has come out subsequently to show that these concerns were probably over-exaggerated. Whilst we were conducting the trial, e-cigarettes became a thing. So about a third of our participants started using e-cigarettes of their own volition. So this was quite interesting. So and we had to think a little bit on our feet about how we might support the use of e-cigarettes within the trial. So in usual care, I think we saw what we expected, and that was when people expressed an interest in quitting smoking, when we signposted them to standard NHS smoking cessation services, very few of them actually engaged with that intervention. Because they were interested in cutting down or quitting, about a third of them started to purchase nicotine replacement products over the counter, OTC, and we find that a similar proportion were also self-medicating for nicotine dependence using e-cigarettes. So the big difference there was this was a supervised withdrawal program, and we know that that is likely to be a more effective way of helping people to quit. So what were the results? Remember, the primary outcome of interest was successful and sustained quitting, both at 6 months and at 12 months. So let's see what the graphs show. So at 6 months, we can see that we've pretty much doubled the proportion of people who quit smoking. So the blue bars there represents people who got this bespoke smoking cessation intervention. And we can see that this difference between the groups has become a little bit attenuated at 12 months. And if we were to use a frequentist approach about whether this was significant or not, it just falls the wrong side of the significance line. But there are a couple of caveats with that. We can see that this is in the same direction as that which we would expect for what we know to be an evidence-based smoking cessation intervention. And I remember, if you remember from a few slides earlier, we tried to set some of the parameters for the design of our full trial from the pilot trial. And one of those was trying to decide how big the trial needed to be to detect a difference. So the statistical power and the size of the trial was based on some estimates of the quit rates in the control group that we observed. And we found that we overestimated those quit rates, and it meant that our trial, which had been set to achieve 90% power, had substantially less power than we anticipated. So when we got our statistician to look at this again once the results were in, they said in a post hoc analysis it probably only had 50 to 60% power to detect the difference that was there. So so despite being the largest trial to date, SCIMITAR was still underpowered to be able to detect this difference that we thought was important at 12 months, so sustained quitting. So the people who are statistically minded within the audience would recognise that we probably made what is termed a type 2 error. So anyone who struggles with the difference between type 1 and 2 errors needs to pay attention to the next slide, because I think it illustrates it quite nicely. So type 1 error being made in the left there. So we've got a chap who turns up at the doctor's and the doctor says, "You're pregnant." He says something's there when it really isn't. We think what happened in this trial might have been a type 2 error, which is what happens on the right. This lady with a bump in her tummy gets told by the attending physician that you're not pregnant. So we think we've made potentially a type 2 error, and the chances of making a type 2 error are very much higher because we had an underpowered trial. So you remember that we did a pilot trial and a full trial. So and by and large, they were the same trial, same intervention, same outcome. The pilot trial was a mini-me trial, but it wasn't the smallest pilot trial that's ever been undertaken. So we thought one of the things that we could do might be to increase the power that is available to us to try and answer this important question: is there an effect at 12 months? So we pooled these two studies. So we pulled together the results of the pilot trial on the left and the full trial, which was also published in Lancet Psychiatry on the right. And we conducted a meta-analysis and then published this in the British Journal of Psychiatry to see if we could get some insight into the longer-term quit rates in this population using this intervention. So here we've got a forest plot that illustrates if we pull these two trials together, both of which are on the right side of this forest plot line that suggests it's effective, the pooled estimate really clearly points to this being an effective intervention at 12 months. And this makes us more confident in saying that this is something that enables people who use mental health services to successfully quit and successfully quit on a sustained basis. We looked at a number of secondary outcomes, and I hinted at what those might be. So we also noted some reduction in the number of cigarettes that people smoked. We saw some short-term improvements in terms of people's physical health as they successfully quit smoking. And that concern that sometimes comes, and I talked about on my myth-busting slides, that quitting smoking is bad for your mental health. We didn't pick that up. So we saw no changes in levels of depression or anxiety. It didn't make people better, but certainly didn't make them worse. And I mentioned that we also kept an eye on people's weights. So amongst those people that successfully managed to quit smoking, we did note this increase in BMI, probably equivalent to about 4 or 5 pounds, I think. And we know that this is an additional health burden that people experience, and for a population of people who are at risk of diabetes and pre-diabetes, this is something else that we noted within the trial. So quitting's good for your health, but also makes you put on weight. So I work at the University of York. The University of York is the cradle of civilization for health economics as a science. So it would be remiss of me if I were to not talk about the cost effectiveness of this study. So this is quite a nice thing for me to be able to present, because this is hot off the press. This is a paper that's currently in press and available in pre-publication on the website for the journal Addiction. So if we were to convince service managers and people who think about the value for money of new innovations in NHS services, they often ask us, well, you know, what is this a cost-effective intervention? So we can answer that question with some certainty now, based on the results of the cost-effectiveness that was embedded within the SCIMITAR trial, where we looked not just at the cost, but also the healthcare benefits that people experience when they pass through this randomized comparison. So this was a trial with a 12-month follow-up. So we looked at cost effectiveness within this 1-year follow-up period. So economists call that the time horizon for our economic evaluation. And in the scheme of things, this is probably quite a short-run cost effectiveness analysis, particularly when we think about the cost effectiveness of smoking interventions, where the benefits of quitting smoking are often realised at 5 and at 10 years through the avoidance of long-term health problems or increased mortality. So you expect the prevalence of chronic respiratory illness and heart attacks and strokes to go down, but you won't really see that until 5 or 10 years. So we didn't capture that, but we did try to capture the short-run benefits in terms of people's physical health and also their service utilisation. So we added up all the costs associated with the delivery of this bespoke intervention, and also the costs associated with training people to deliver it, including, you know, the hourly rate of our people who trained our support workers, the materials that we developed for patients, the costs of sandwiches on a 2-day training event. So this was all added up, and it came to about £196 per participant. And we also looked at people's utilisation of NHS services to see if they use the GP or inpatient mental health services or medication costs, see if they came down as we expected that they might do. And we know that very few people in the usual care access stop smoking services, so this wasn't a cost burden that we had to work against. And when we did the sums, and I'll show you the picture that emerged from the cost effectiveness analysis, we found it was 57% likely to be less costly. So the costs associated with the intervention itself were offset by reduced costs in the NHS. So people went less frequently to their GP. They used NHS mental health services less frequently, and there were reduced medication costs because they reduced their levels of medication. And it also resulted in some improvements in their quality of life. So this is the sweet pot for economic evaluations. And when NICE seeks to make decisions about whether things are cost effective or not, they often set this arbitrary cost effectiveness threshold of £30,000 per quality adjusted life year, the way in which we measure quality of life in these sorts of studies. So it's 80% likely to come below this threshold. So this is the sort of thing that NICE tends to endorse. But as I've already mentioned, the benefits of quitting are likely to be achieved across a person's lifetime. And we've not measured that, but we can model that. And the clever people that work in the health economics team at the University of York are doing that as we speak. And we know that this sits within a broader body of research that always shows that smoking cessation is one of the most cost-effective investments that you can make anywhere in the NHS. So that's also true in mental health services. So there's the picture from the cost-effectiveness plane. So I'm not going to dwell on this, but I'll put a link, and perhaps we can send around a little bit later the cost-effectiveness analysis. But I think it illustrates the cost-effectiveness threshold for this trial. So I've got some reflections on the trial. We got the results in about 2 years ago, and we've sequentially been publishing some of those results over the last couple of years. So I've tried to say there on the left what went well, or what we might do even better on the right of this this costs and benefits kind of slide. So this was an important question for the NHS. It had been prioritised. And I think we answered this question. We can help people quit safely and effectively and without the detriment to their mental health. And this was a big trial. We recruited in 21 NHS trusts. We recruited in Cambridge and in Peterborough. We recruited in North London, and we recruited in all parts of Yorkshire. So the geography and the social and economic and cultural spread for the participants was pretty broad, and we think these results are pretty generalisable. We got really good long-term follow-up rates, and that's one of the things that I guess increases our confidence about the quality of the science within this randomised controlled trial. And we've created a model of care that can be scaled up and aligns really closely with the existing things that happen in the NHS. So the National Centre for Smoking Cessation and Training, which is what that acronym stands for, the body that oversees the skilling of the quit smoking workforce in the NHS, are really interested in the intervention because we can plug this into existing training programmes. And we also learned a lot about delivering trials of smoking cessation in the NHS, and we've got capacity and enthusiasm to deliver future research in this area. So the trial I've talked about isn't the last word. We've got more trials to do in this area, and I can talk about those if people like me to. Now, if we were to do this better, well, it was a trial where we asked GPs to prescribe our quit smoking medication, and there was quite a gap in between people's aspirations to get that medication and our ability to ensure that they received that medication in the trial. And it often took quite a lot of manufacturing and some difficult phone calls to get people to access the prescriptions for that. So I think if we did this trial again, we would actually take charge of the supply of the medication rather than relying on GPs to prescribe it. We know a lot more about the safety profiles of varenicline, and varenicline is more effective than nicotine replacement in enabling people to safely quit smoking. So we think the interventions would have been more impressive if we'd have used Champix as the pharmacological support. And e-cigarettes have come on the scene. So we think if we were to run this trial again, we would have to embrace e-cigarettes and use that as one of the alternative forms of nicotine replacement and support. And we think it's really important to offer some longer term support once people quit smoking to help them stay quit. And it won't have escaped people's notice that these were largely middle-aged participants. What we missed was the opportunity to intervene much more early in people's disease trajectories and illness histories. And we think the next place that we'd like to work is developing interventions that work for younger people. Younger people think they're immortal, but there are ways in which you can help people to quit smoking at a younger age. And we'd like to start working and intervening when people have their first episode of psychosis. And I've already talked about the issue of statistical power, and we did have some a fix for that, but it was a post hoc fix. I think we'd design a bigger trial if we set out. So we think this is an important question. It became apparent it was a more important question as time went on. So as the NHS long-term plan came out a couple of years ago, it was really quite gratifying to see that smoking cessation had moved from being a fringe interest and a fringe activity, something that was of interest to cranks like me, to being something that sat front and centre of NHS policy. So there's a very clear recommendation in the NHS plan about the scaling up of the NHS smoking cessation services for people who use mental health services. So we think we've got some evidence here about how you might drive forward that aspiration within the NHS plan. So I've got a few messages in my last couple of slides before I stop talking. So for people who work within mental health services, I think it's really important that you counter therapeutic nihilism when you encounter it, and that you ask a bit more about smoking histories and have within you a repertoire of things that you might say when you ask if someone's a smoker and they express an interest in cutting down or quitting, because half of your patients will be interested in cutting down or quitting. So you need to know how you signpost them onto effective quit smoking services within the NHS, because there is a learning opportunity there. And we also learned that people feel upset when they're not asked about their smoking history. So that notion of don't ask because you're worried that people will be embarrassed if you ask them about smoking and their smoking habits and smoking history isn't true at all. So, and particularly if you were to ask these questions in a courteous and a respectful way, and not to make people feel embarrassed about whether they're smokers or not. So ask these questions in a non-judgmental way and try to make every encounter count. I've talked about some of the myth busting that has been useful for me over the past 10 years. So be prepared to challenge some of the common misperceptions that are still abound in this area. And I think you should challenge the services in which you work to be responsive to the needs of people who use those services. So there is some injustice, I think, that happens in relation to the allocation of smoking cessation services in mental health services. And you should advocate on behalf of the people who use your services. If you're someone who has a hand in managing medications, if the person whose medication you manage tells you that they want to quit, you should know within yourself how to appropriately reduce the doses of their medications alongside a successful quit attempt. And I think there's still a culture of smoking in NHS mental health services, and I think you should be prepared to challenge that when you encounter it, because the converse is that nothing changes, and the patients who use our services will continue to experience profound health inequalities by reason of inertia and failure to challenge that smoking culture. And becoming smoke-free for individuals and for services really is a journey. So it's okay for people to fail once or twice in a quit attempt, and be prepared to hold their hand and to encourage them to get back on. So I'm pretty much coming to the end now. Here's my summary slide. People with severe mental ill health have some of the highest rates of smoking in any section of the population, and the majority of people who are smokers and use mental health services don't really access conventional NHS stop smoking services. So I presented the results of the SCIMITAR trial, where we've tested an intervention that can enable people with severe mental ill health who want to quit successfully and effectively. The results showed that we get good engagement, and we've got some verified improvements in quit rates, both in the medium and longer term. And we think this is timely. This is an evidence-supported model for service provision. So I guess the challenge is to think about this evidence, how it might fit in within the services that you work. So we've been working with lots of people to try and disseminate and implement this. So we've been working with great people at one of the largest charities that support smoking cessation initiatives, Action on Smoking and Health. Great people. And they've helped us to make videos of some of the people who successfully quit. And we've got some links to those on our website. We've gone back and we've worked with people at the National Centre for Smoking Cessation and Training. We're also working with our funder to think about how we might implement some of this research. So I'll stop talking at that point and just extend thanks to lots of people, including some people who'll be in the audience today. So thank you very much for your attention and for your collaboration and help. And back over to Emilio. Thank you for your attention.
Thank you very much, Simon, for such an interesting talk. So many questions I have as a clinician, looking after people with severe mental illness, and a lot of them, 30–40% of my patients smoke. There are some questions, and starting with the big one from Peter Jones. So Peter was asking two questions. One, what has been the practical impact in the country about the SCIMITAR trial? So are people adopting the trial and the results and changing things? And the other is, will the relaxation of the non-smoking policies in mental health settings during the lockdown have pushed back perhaps the progress of all what you have been trying to achieve all this time?
Good questions from the big guy. So thank you, Peter, for your attention. So I guess the first one there is about impact. So I'll answer that in two ways. So I'm thinking about the service that I work in. So Tees, Escombe, Weir Valley, NHS Mental Health Services participated in this trial, and we were able to tap into a great level of local enthusiasm. People wanted to know the results of this trial. So there was an institutional memory. We trained lots of people up to deliver this intervention, and that meant that once the results came back for the trial, people owned it locally. And I think it's been instrumental in keeping up the momentum from participating in research to actually translating some of the results of research into local services. So we're able to use some of the training materials as a template for local professional education, and it's become not a mandatory, but sort of like approaching a mandatory training requirement for everyone working in the trust to at least have level 1 competencies from the National Centre for Smoking Cessation and Training. So it's been useful in the services where I work, and I've heard that story in quite a few of the hospitals and services that participated in this trial. But the other impact is probably at the more macro level. So we work really closely with a third sector organisation, ASH, Action on Smoking and Health, and they've got a really good partnership between the community of researchers working in smoking cessation, tobacco addiction, and people who are also interested in this at a national level. And so I've worked quite closely with colleagues from King's College London. So Professor Anne McNeil is a fellow academic who works in this area, and ASH have been really good at lobbying at the highest level within government, and also producing really good information materials that summarise some of the research evidence and contextualise that in terms of the health gaps that exist for our population. And ASH have been tremendously helpful, and when we had the results of the trial, I think it instilled them with a sense of enthusiasm that they'd got some proper research that had been framed in NHS services that they could wave in front of decision makers and commissioners, and having the results of this trial really enthused and gave us more momentum in the liaison group that we have between the academic community and Action on Smoking and Health. So I think those are the two sort of my personal reflections on insight. The second question was about whether we've lost momentum in terms of smoking cessation in mental health services with COVID. So it's a difficult one because the smoking rates have gone up in the general population as a consequence of COVID, despite the fact that we know that people with smoking-related illness have some of the highest risks of doing really badly with COVID. So it's a poor prognostic indicator if you've got smoking-related illness. There was a slightly spurious argument that was kicking around for a few weeks about whether nicotine receptors, if you were to tickle your nicotine receptors, then it reduced the chance of you actually contracting COVID. But I think that's pretty much been dispelled. But that was a really unhelpful public health message to kick around at the time. People took to mean that if you continue smoking, you're less likely to catch COVID, and I don't think that's true. We do know that if you've got smoking related illness, you're more likely to die from COVID. So my understanding is that smoking rates have gone up within the broader population. We know this from some of the population surveys. I've yet to see any substantial evidence that people who use mental health services are smoking at a higher rate, but it wouldn't surprise me if that happens to be the case. So I think it's really important when we think about the post-COVID world that we think about sending positive messages. And there was a really good example, an initiative that came out from Bristol. And NHS Quit Smoking Services moved from being a face-to-face initiative to being an initiative that's delivered at distance. And there was a GP working in Bristol who ran a campaign called Quit for COVID, and sent a really positive message that if you wanted to maximise your chances of coming through the COVID pandemic, one of the really positive steps that you could take for yourself would be to quit smoking. And there were apparently 300,000 people in the broader population that gave up smoking in response to COVID. My anxiety, as with all things, is that people who use mental health services would have been or felt excluded from such initiatives. So I think it's got the opportunity, it's got the potential to amplify some of the health inequalities that we know exist for smoking. So these are difficult times, so it's really important that we sort of stay focused and on message and embrace some of the evidence that we now have available.
Okay, so there's plenty of people asking you questions. The first one arrived through an email from Ulrich Muller. Is what is your opinion about the bupropion and the role of the bupropion, considering that the GPs might like it a lot?
Oh, interesting. So bupropion has some antidepressant property. So it's the antidepressant that's used as an aid to quit smoking. And if you look across the globe, particularly in the United States, bupropion is a commonly prescribed medication. However, if you look at prescribing data from the United Kingdom, it barely registers on the dashboard. So the most commonly used quit smoking medications in primary care are varenicline, Champix, and also various nicotine replacement products. So bupropion is there and it remains an option in the BNF, but by and large, I can probably count on one hand the number of people who received bupropion in our trial, but there's a nice summary paper that was produced by the British Pharmaceutical BPS, who summarised the safety profiles and the effectiveness of all the available quit smoking medications. And bupropion's there, but it's used with caution. So I'm not a psychopharmacologist, so I always I'm always keen to point out the limits of my expertise and experience in this area. So rather than me go on and make a fool of myself about bupropion, it wasn't an issue for us in this pragmatic trial.
Chronologically, the next one is from Graham Murray. Graham, would you like to speak out on your question?
Hi, yeah, thank you. Thank you very much. I actually was a bit related, but perhaps the paper you mentioned might be a good go-to point for those of us who'd like to do some prescribing for initiating smoking cessation medication, but we haven't had experience or we're not confident about what to prescribe. Do you have any tips?
Yeah, so two tips. So first of all, ask the questions to ensure that people can give a positive response about wanting to quit smoking, and more people will respond positively than you suspect. And there's really good trial-based evidence that shows that giving very brief advice is a really useful thing to integrate into your personal consultation style and repertoire. So I think that's true for doctors as well as nurses. Everyone who works in the NHS should be able to ask those questions, and there are good ways of asking them and poorer ways of asking them. So rather than immediately reach for your pen and the BNF, I would suggest that you log on and do the 30-minute training video that's available on the NCSCT website. So that's really transformative. I've started using it with the medical skills, with the medical students at our medical school, for example. But I do think it's a core professional competence for myself as a psychiatrist to know how to prescribe quit smoking medication. So rather than sending people back to the GP, I think we as psychiatrists, the psychiatrists in the room, should feel comfortable being able to prescribe varenicline, comfortable being able to advise people about how to correctly use nicotine replacement. So it only gets you so far being able to prescribe it. Being able to advise people on how to use a patch, for example, or how to use gum correctly. One of the things that we noticed in the trial is that people chew the gum for about 30 seconds and then swallow it, which doesn't actually give you that hit of nicotine, which you hope people to achieve. So really useful techniques like chew it for 30 seconds and then park it under your lip. So this sort of park and chew technique is really helpful. And I guess the final reflection is, and there are good guidelines on what to do about reducing each of the psychotropics that we prescribe as well. So most people I encounter in the NHS really don't like taking medication. So the prospect of being able to offer them a lifestyle intervention that means that they take fewer tablets or lower doses of tablets is something that's actually quite a positive message to be able to sell to people, and they quite like the prospect of giving up smoking and taking lower doses of medication. So and I remember the conversation, one of the first conversations I had with Professor Robert West. You should really feel comfortable using nicotine replacement. So Robert West said, don't be anxious about prescribing too much nicotine replacement. So give people nicotine for as long as they want and as much as they want. And if they're still getting withdrawal symptoms, keep up in the dose of nicotine. So the people who use our services are going to be some of the heaviest smokers anywhere in the NHS. They're going to have the heaviest levels of nicotine dependence. So dosages that are often suggested in the BNF as starting doses, you could probably start very much at the upper limit of those. So those are my sort of like 5-minute takeaway messages for people who work in the NHS, particularly those who prescribe.
Okay, a couple of more questions, Simon, if you don't mind. Can we extend for 5 more minutes? It's one from Rick Harris. Is the NICE quality assessment now recognizes the impact on caregivers? Has any assessment been considered for this within the SCIMITAR study? Good
question. So we took that vanilla, straight down the line, NICE perspective as NHS and personal services perspective, and you're quite right that we are able to broaden the perspective of economic evaluations, and NICE is keen to consider evidence that an intervention actually might impact on caregivers, and their time and the costs associated with caregiving can now be a perspective that's included in economic evaluations. But we didn't do that, and if I were to look at this in the future, I think it would be really interesting to add that additional perspective of cost. So caregivers are often the people who might also be helpful in ensuring an effective quit smoking intervention, and we spent a lot of time also working with caregivers when we planned quit attempts. And often people are in smoking dyads, so a lot of people in the trial actually got their partners to give up at the same time, and we weren't able to capture that in the trial. So we imagine that a successful quit attempt, when it happens in a couple, is a dividend that pays off twice over.
Thank you. And the last question from Sharon Neufeld is, you mentioned that you're maybe thinking of tailoring this intervention for young people with first episode psychosis, but she was wondering whether this intervention can be also, whether you are thinking about using this intervention in adolescents or young people with more common mental disorders like depression and anxiety, and whether what sort of barriers or what sort of problems or challenges do you anticipate that might be posing?
Yeah, so I mean, this is really interesting. We started with the question that was posed by the NHS in this commissioning brief, and that was very specifically to focus on people with the most severe forms of mental ill health, so people with schizophrenia and bipolar disorder, and that's who we got in the trial. And we think that there is a trial to be done amongst people with anxiety and depression. The question is where that might be delivered in the NHS. So one of the ideas that I have in this area is that it might be integrated into IAP services, for example. So it might be one of the things that people who deliver IAP services could very readily be skilled and able to deliver, and particularly if they're encouraged to ask the quit smoking questions in a sensitive and evidence-based way. So I think you could do more in services that serve the needs of people with anxiety and depression. But the vast majority of people with anxiety and depression are entirely treated within primary care. So I guess the take-home message is that quit smoking services in primary care should be for all people, including those with anxiety and depression. But the specific aspect of the question was around younger people's services. So we've had lots of interest from people who oversee child and adolescent mental health services about how they might integrate smoking cessation interventions into their services. And there's no reason why they might not do, but that's one of those sort of service innovation type questions. And we think there's pretty good evidence that you can get young people, irrespective of diagnosis, to either not start smoking or to quit smoking if they start quite early in their illness journeys.
I think we are closing now. Simon, just to thank you a lot for this talk, which is not only, in my view, and perhaps that's my last comment, it's not only about the content, but also shows the full esteem of the machine of the research in UK, where has been funded by the HTA, has been helped through the CRN to implement the your ideas through in the whole country, and how that might change finally how we can help people with severe mental illness and the smoking. So thank you very much for giving us this this seminar today, and for being our first guest using the Teams, and I hope has gone well. And thank you to everybody. And I don't know if we can do any clapping, but that's
So thank you, and also I'd like to thank people who arranged the tech in the background. So we spent a bit of time getting this right, and I think the time was well spent. So thanks for everyone who helped make this happen today. So thank you.
Thank you to everybody. Bye bye.